Okay, at this time, I would like to introduce our next speakers, Dr. Sally Wicher and Jane Ormerod. They will be discussing long COVID in Scotland. Dr. Wicher has worked throughout her career on poverty, inequity, and exclusion. Former roles include the chair of the Scottish Commission on Social Security for the Scottish Government and the Disability Employment Advisory Group for the UK government. She has also served as CEO of Inclusion Scotland, the Child Poverty Action Group in the UK, and senior civil servant in the Office for Disability Issues. She has a PhD in Diversity and Social Inclusion, University of Edinburgh, and an honorary doctorate, University of Stirling. Jane Ormerod worked in the National Health Service for 40 years until retiring in 2013. She has a professional nursing registration and an education teaching qualification. She has worked in a number of clinical and educational roles and has participated in a number of health-related research projects as a researcher and a supervisor. She also was a member of the local ethics committee for 5 years. Since contracting COVID in early 2020, Jane has had long COVID. She is a member and volunteer of Long COVID Scotland, which is an advisory group for people with long COVID. She currently serves the Long COVID Scotland Board. So at this time, I would like to turn the floor over to our first presenter, Dr. Sally Wicher.
Thank you very much. I'm really pleased to have this opportunity to talk to you today. I really welcome finding out more about what's happening across the world on an issue that we're all working on in our different ways in different countries, but very often in quite a similar context. So I'm going to start my presentation by talking a little bit about context, because I think in order to really understand what's happening, or rather more significantly, what isn't happening around long COVID, it's important to understand the backdrop, because that informs what then ensues. It's very clear that, as I said, long COVID and COVID, the ongoing pandemic, this is a global issue. And my experience of meetings with bodies like the World Health Network is that there are huge similarities in terms of the kinds of barriers that people advocating or trying to get this taken seriously are experiencing, and a great deal of useful learning that we can share between ourselves. In the UK, a very key part of the backdrop is around the privatisation of public services, that being a major priority of the UK government. Whether or not it's ever put that explicitly is not necessarily clear, but that is what is happening, and it's very, very evident. And in particular, the privatisation of the National Health Service, which in the UK, as you may know, is publicly funded through taxation, and it is free at the point of use based on need. So very different to the private sector model that applies in the States and in other countries. But that is being privatised in all kinds of ways, very much by the back door, not necessarily up front. I think it's also important to situate this discussion within the context of a huge amount of existing learning that's around that isn't necessarily immediately obviously relevant, but actually is, as well as the ongoing new learning that is happening. So there's a lot of joining the dots to be done. And I mean between different groups. I'm thinking, for example, of learning from, say, HIV groups, when in the context of the AIDS pandemic, there's environmental groups working on air pollution. There's the disability movement, and a huge amount of learning there about challenges around the medical profession and political traction, and across countries and related issues. I think it's important to think about long COVID in the context of prevention. You have to look at this holistically. If you're only looking at one stage of a process, you're going to miss what happens before and after. And so we have to, I think, talk about prevention as we talk about long COVID, as well as what then follows in terms of treatment. So my question is, with all the learning that we have now, whether a safe, inclusive new normal is feasible. And it seems to me that it very clearly is. This is the way things are not inevitable. It doesn't have to be this way. And with that in mind, and as a person at high clinical risk from COVID and a disabled person for most of my life, I set about trying to do something to tackle this and have set up an organisation called Inclusive New Normal, which I'll say a little bit more about later in the presentation. But the key goal of that is to drive forward learning arising through the pandemic and think about how that applies not just directly to matters coming from the pandemic, but other areas such as air pollution. So I want to say a quick word about how devolution works here, because it isn't automatically obvious, including, I have to say, to people in the UK a lot of the time. So in Scotland, healthcare is devolved, as in the Scottish Parliament, the Scottish Government has policy control and can decide how it wants to spend funding. However, there are all manner of ties and constraints. The UK government sets the funding total. And whereas Scottish government can decide what it's going to do with that up to a point, it has real challenges getting any additional funds unless it takes it from other areas of its budget, again determined by the UK government, very limited tax raising powers. Hence, that said, where it does have scope to do things differently, when it concerns COVID, it has chosen not to do that to a very great extent. From the early days, they threw their hat in the ring along with the other members of the 4 nations that make up the UK and joined forces with the UK government, I think, to the likes of me and others who are directly adversely impacted by COVID. This was a somewhat inexplicable thing for them to go and do, when government that is led by those concerned around independence had so much scope potentially to show how different and better they were from the UK government. There were 1 or 2 practical reasons around procurement, for example, a vaccination. It made sense to kind of do that together, perhaps. But beyond that, there were things that really made no sense in terms of very differently politically aligned governments joining forces on this. There's some infrastructure that we share with the rest of the UK, like where it concerns health and safety in the workplace, but not where it concerns things like health and safety in care homes. So that's an added complexity. Sometimes Scotland has led on bad policy. For example, there are the manuals that health and social care workers depend on originate from Scotland. They've been adopted by the other 4 nations. They say just about nothing on the prevention of airborne infections in health or social care settings. So this is extremely unsatisfactory, and the body that writes these manuals is extremely unaccountable and not transparent. There's then devolution to health boards. There are 14 of those in Scotland, and again, so quite a lot of variety ensues due to that. And then we have inquiries. I don't know if these are things that you have in other countries as well. I'm not sure you do, but there are governments set up inquiries in the UK, but also a separate Scottish one. And these are proving in some ways very useful, because it does mean organisations such as Long COVID Scotland and Jane last week have the opportunity of being heard in that forum and putting their case. So these have some advantages, although whether these inquiries are asking the right questions about the right things, personally, I am not convinced. A lot of distraction about who deleted what WhatsApp message and whether about that rather than the actual decisions that were taken and why they were taken and whether they could have been done differently. Anyway, I'll move on. And here's a recap of Scottish Government's approach. So they have adopted what they call a living with COVID policy, which basically means carry on like it wasn't there. Ignore it. Do not even dare mention it. It is not a thing. The pandemic is over. It is all minimizing and denial where it's even mentioned at all, because increasingly it's not even mentioned. There is no acknowledgement that I've ever seen, Jane will correct me if I'm wrong, publicly, of reinfection increasing risks of long-term sequelae, including long COVID. There has been an overwhelming focus, as throughout the rest of the UK, on acute illness and hospital admissions. A narrative that is being perpetuated that COVID is just another seasonal respiratory illness. It's fairly mild, most is a bit of a cold. And of course it isn't. And their very own data clearly shows that it isn't. It's seasonal. Here's a dashboard from Public Health Scotland, which shows that COVID is not seasonal in the way that others are. And they've dismantled data collection. And it seems to have been done in some cases very strategically, which means that trying to find out what's going on is a major headache. We can ask, and we do, a lot of freedom of information requests, and that is actually quite an effective process of getting them to cough up the information. But it isn't necessarily, it is not publicly communicated, it is publicly available once you ask it, but the vast majority of people have absolutely no idea that COVID is still a thing, that long COVID even exists. So that's kind of where we're at. It isn't great, frankly. They view vaccination, and have done for some time, as this is not just a game changer, it's a game winner. It solved it, the end. Anyone who's not immunocompromised or elderly, you've got no more risk than anybody else. Of course, that's absolute nonsense, because people with, say, like myself, with multiple comorbidities, we can't tolerate any more additional damage. And of course, people who are exposed multiple times in certain environments have much higher exposure risk to reinfection and hence long COVID. But most ridiculously of all, having made such a big thing of vaccination, it's been unavailable to most people. And so most people haven't had access to boosters. They haven't been able to get them privately until this month. So again, utter contradiction, which is what marks government policy. I've mentioned the care worker manuals. There's a culture in the NHS of following the guidance. The guidance says we don't have to is the refrain, or the guidance says we have to. People who've had clinical training who must know that what they're doing is wrong, is not effective, is actually extremely risky and counterproductive, operating with the mantra that of do no harm, are doing harm, but still hiding behind the guidance. And here's a little example of how, so we say strategic data removal. In May last year, Scottish Government removed extended mask requirements in healthcare and social care. These days, pretty much, they just don't wear masks, generally speaking, unless it's for what they call an aerosol generating procedure like intubation. But masks, including surgical masks, are not necessarily worn. And people who go into healthcare settings are routinely told to remove their mask because you don't have to wear them anymore and put under some pressure. Meanwhile, a couple of months before they did this, they stopped collecting data about hospital-acquired infection, which means it was impossible to track what impact that had, the removal of masks, on hospital-acquired infection and the extent of it. The kind of recurrent refrain from ministers is we take long COVID very seriously, but meanwhile they minimise it repeatedly. They've allocated £10 million, which is not even loose change down the back of the sofa in governmental terms, and that's over 4 years, and they've underspent it. It's just unbelievable. So that's what the Scottish Government think. They don't know how many people have got long COVID in Scotland. They've allocated a tiny amount of money, and that's them taking it seriously. So here are a few facts and figures. So I mentioned data hasn't been collected, but the best data we have, and most of which comes from about a year ago or before, approximately 187,000 people in Scotland have long COVID. As a percentage of the population, that's higher than the UK on average. Social care and healthcare professions are at the top of the long COVID league table of professions, along with, you'd be unsurprised to learn, teachers. So there has to be a link between exposure and long, as we know, because of reinfection. But that is simply not acknowledged, and there's no data on that now. But one thing they're having to acknowledge reluctantly, and they're trying to find as many reasons as possible as to why it's actually a people's personal choice not to be active in the labour market or whatever, is economic inactivity due to sickness is at record high, and that is starting to cause problems for the economy. We have a sick economy, and people who otherwise are perfectly happy about not respecting or in any way attempting to protect the well-being of people who are much more concerned to respect and protect the well-being of profits are starting to sit up and take notice. So just a couple of recent reports. This is from Chest, Heart and Stroke Scotland. 40% of people living with long COVID are unable to work at all, and there's some stats around that. 72% of people with long COVID said that there was support they needed that they couldn't get. 82% encountered some difficulty in accessing services or even any medical support, and 38% said their doctor wasn't able to provide guidance on available support. One of the features of this is that GPs, the frontline medical health providers, are, how can I put this, clueless, I think. They do not know. And even if they do understand what's going on, they have very few powers to do anything about it. Another one kind of report from the Health and Social Care Alliance reinforced a lot of this. And here again are some stats. I think an interesting one here is that nearly half of their respondents disengaged from a long COVID service. So even where services are supposedly there, they're not doing the job and people are not using them. There's also evidence separately of people at high clinical risk not engaging with healthcare services, where even their consultants who are seeing them because they're at high clinical risk are not wearing masks themselves and telling them to remove their masks. So there's some real problem here. But of course, what happens as a consequence of NHS support not being there is that people turn to private healthcare. And that's very much one way in which I would suggest that agenda is being driven. So a quick recap of some general challenges. And I think some of these will be very familiar to people on this call. Political structures and ideology. We're battling against, in our case, a very dysfunctional political system. One commentator suggested that what COVID did was to act like a barium meal, in that it showed up all the problems, the dysfunctions within the political and service delivery and other systems. It revealed them, of course, it also made a lot of them worse by putting them under additional stress. We have a mainstream media that is so not interested in the reality here, that is so pushing lockdown is what's caused all this. Still, years later, all the things you see that are bad, that you cannot deny, are down to the impact of lockdown 2 or 3 years ago for a few weeks. But people are sort of not questioning this, which is quite distressing. There's some big issues with the law in our country. Firstly, obviously, in terms of how it's framed. So we have an Equalities Act. But people who are at high risk, for example, are not necessarily covered because it's about being a disabled person, not risk of becoming one. And people at high exposure risk, similarly, are not covered by it because it's about risk, not necessarily eventuality of becoming disabled. Many people with long COVID will be covered by it, but it's not well framed. Neither are laws around environmental standards, building regulations, hate crime, you name it. And then there's challenges about how to access it, because in this country, that is far from straightforward, and it's very, very expensive. There are all kinds of vested interests around. I've already touched on a medical culture, which is very problematic, I think, because of the hierarchy, the unquestioning, and the challenge where whistleblowers have a very, very rough time. And there's challenges too about demonstrating where COVID was caught. If, for example, you wanted to hold your employer to account, you need to show you caught it in the workplace. Tricky, because you could have caught it on the bus, you could have caught it anywhere you've been, and you need to show whether it's permanent or not, which again is not necessarily a straightforward thing to do. So just a quick recap of some, again, narratives I think that will be familiar to you. We saw last week, Long COVID Awareness Day, a concerted push from certain countries and media institutions that long COVID is really, we don't need to use the term anymore, it's just another post-viral syndrome thingy, like any other one. It was deliberately timed to coincide with Long COVID Awareness Day to kind of blow a bit of a hole in that, in my personal view. And the so-called research it was based on was, well, it wasn't research. It was like getting a bunch of people with fatigue into a room and declaring that because they all had fatigue, they all had the same problem, which is, and were suffering from the same condition. It's absolute nonsense, but it was uncritically reported by our mainstream media. There is some issue, I think, around how to distinguish, or if it's even meaningful to do so, though, long COVID and the various conditions to do with that from all manner of sequelae, such as incidents of heart attacks and strokes and other things that may express themselves differently. And of course, those aren't tracked at all. So when they're giving things like hospital admission data, they're talking about acute infection. They're not talking about all the things that follow from a dysregulated immune system, from a long COVID, and from all the other sequelae that can follow, because it's just not tracked at all. There's obviously limited understanding around risk and how narrow that is, where it's even recognized. And in fact, the herd immunity idea is still alive and well. It seems to have its own form of immunity from logic. And yeah, that's still being pushed. It doesn't matter how often you can show that it's nonsense from bona fide, very, very good research. And what a lot of this has resulted in is what I would say is a kind of political push, which feels very much to those on the receiving end as gaslighting and bullying. And I've got a little example here. This is a current campaign by the Department of Education, which is basically telling parents, your kid may be sick, but make them go to school. And there's a number of these ads running. They've been thoroughly disliked and complained about by parents. But there have also been instances of parents being taken to child protection services because they're trying to keep their child safe quite reasonably. So there's some fairly unpleasant stuff going on. Action, I think one of the very exciting things that's come out of COVID, actually, was how it meant that use of online platforms like we are doing now suddenly became widespread. And it's given rise to the birth of a whole new, what you would call, I think, a non-profit sector. And in the UK, lots of little different organisations sprung up very rapidly. People who would have been very, very isolated haven't been. And they're organising. And it's enabled global networks to take shape. Pre-COVID, my networks locally, in real life, physically, were pretty big. My global network's pretty much non-existent. That's reversed, and I think that's true of a lot of people. And then there's a lot of action around Long COVID Awareness Day in Scotland. We have a cross-party group on Long COVID here. Jane will know more about them than me. She's had more involvement, but there is a protest and a debate in the Parliament. And I mentioned the inquiries. And I think what I'm seeing is that, and what I've tried to do through Inclusive New Normal, my organisation, is to bring different people, these new organisations together, and experts around things like clean air and infection prevention control and so on, to work together. And because what we're doing, I think, here is building something that could become a new movement. Here are just a few links I thought I pulled together, some relating to material I've referred to, and one or two others as well, in case you wanted to have a more thorough, in-depth look at any of those. And finally, just to wind up, this is my organisation. It's a social enterprise, not a charity, and that's its mission. It's also about driving, obviously, forward learning arising through the pandemic towards the goal of a safe, inclusive new normal. But it's also about amplifying and supporting the voices of others with aligned goals. And there are my contact details. And thank you very much indeed for the opportunity to talk to you today.
Well, thank you very much. Needless to say, that was a very educational and thought-provoking presentation. I can assure you that regardless of your political dysfunction in the UK, we have our own in the United States, which we are very desperately trying to deal with. Now let's move on to our second presenter, Jane Ormerod from Long COVID Scotland. Ms. Ormerod, you have the floor.
Well, I'm going to, and I should thank Sally. She gave a superb introduction to where we are in Scotland, and I'm going to be speaking about my lived experience of having long COVID and trying to use that experience flexibly and productively to move forward. So my journey so far, Kevin already said I have previous experience in the health service and in a number of roles, as he explained, until I retired in 2013. And then I worked as a coach and a facilitator and a volunteer. And then I developed COVID, it's about 4 years ago to this very date, really, and then had developed long COVID after that. So I'm coming into my 5th year of having long COVID, and unfortunately still having lots of symptoms. But fortunately, I got involved in Long COVID Scotland, and that was in 2020. And Long COVID Scotland had just formed at that point as an advocacy group. We were initially a social media group, a Facebook group, but I'll talk a little bit more about that in a while. I then got involved in a number of research projects in the early days, 2020-21, as patient and public involvement, and a co-applicant and advisor to a number of projects across the UK. And I also got involved in service development locally and nationally. So a number of things going on. So a little bit about Long COVID Scotland. We're a volunteer-led charity. We became a charity in 2022, and we advocate for people with long COVID in a range of issues, as you can see on the slide here. But really, we are campaigning for better access to diagnosis and treatment. They are huge issues for us, as Sally's already spoken about. You get some idea of what the health service is like in Scotland. We also advocate for robust research around employment and local and national policy to do with all of these things. We've had quite a lot of achievements. In the early days, we ran quite a few open sessions, conversation cafes for a number of participants, people with long COVID, researchers, coming together to talk about what we could do to take things forward. We have run hustings for members of the Scottish Parliament. We became a charity, as I said, in 2022. And this year we have, for International Long COVID Day, we had a protest, if you like, at the Scottish Parliament. A number of people came along, and we met a number of MSPs as well to try and advocate for everybody in our group. So we've done quite a lot of things, but so much more to do. The challenges around that, I'm sure you can anticipate, really, they are about us being heard primarily. And Sally spoke about a number of reports that have just been published in the last month, talking about the lived experience of people with long COVID. And one of the biggest challenges we face is the insistence by government that they provide a long COVID service, when our members are very clearly saying what they have access to, or if they have any access to, is not a service that meets their needs. So something's missing a mark somewhere, and that's what we are faced with at the moment. These are a couple of, well, they're 3 photographs from our protests last week. We've got a lot more slides, and we had a lot of people outside the Scottish Parliament with a lot of banners. We had a declaration that was signed by a number of MSPs. We were in the local news, we were on the national news. We got really good exposure. It was a very interesting day for me, particularly because in the morning I was speaking to my statement to the Scottish COVID inquiry. My statement ran to 30 pages. Fortunately, I didn't have to speak to all of that, but I was asked a lot of questions about the work of Long COVID Scotland and our view on the state of current services. So it was a very interesting day. These are all things that I've had said to me in the last 4 years in one way or another, and they are most definitely not true. My point in putting this slide up is that this sort of a gaslighting and denial and lack of listening of what's real for people with long COVID erodes trust and confidence in persisting with your own journey. And for me, I was looking to make something positive out of this. I've had a lot of ups and downs over the last 4 years, both with my physical symptoms and indeed with my mental health in terms of keeping myself on an even path. So it was just really trying to find a silver lining in it all for me, and getting involved in PPI work enabled me to do that. I wanted to use my frustration productively, and when I saw opportunities to use them, there is something as well, not just for me, I think, but for anybody with long COVID. And many of my colleagues have lost their jobs. They have had to leave their houses because they couldn't pay their mortgage. So looking around and thinking, well, I can't do anything. My life's not the same. For us, part of our work as an advocacy group is really supporting people to think, well, what can I get out of this? Is there learning? Are there new skills that I can develop? And what support do I need to do that? And for me, that was definitely part of it. And part of it, a big part for me as well, is my own limiting assumptions and those of other people's as well. Having worked in the health service previously, I was on the other side of the fence. And now I'm somebody who's had a chronic illness and will continue to have that, I'm sure. And getting used to that and thinking how I can use that is an important way of moving forward. So it is challenging how things are done around here. And persistence is key. And I think one of the main things that I've learned, and I think we all have learned, is to put your own oxygen mask on first. You can only do so much, and having a fairly good grasp of where you are physically is a really important thing. For us in Long COVID Scotland, until recently, and we still are a very small group of active volunteers, we have a larger membership of people, but we have a board, for instance, of 7 trustees, and we have about 10 active volunteers. Now, we all have long COVID, so that's a huge challenge, juggling the fluctuating nature of long COVID. And recently we were joined by 2 people who don't have long COVID. They're people who are carers for people with long COVID. And that has been an absolute revelation to have people involved in our work who don't have long COVID. It makes it a lot easier. So conclusions really then, I think in all of this, building trust is essential, and I'll capitalise on what Sally said. We have to work together. Scotland is a relatively small place and we all tend to come across each other at one point or another. So working together is essential and building trust is essential. I think it's important to have a clarity of approach. For us in Long COVID Scotland, we have a manifesto. We are clear about what we're asking, and we use that in our experience at the Scottish Parliament last week. We prepared handouts for the members of Scottish Parliament around what we are looking for as a charity, and each of the MSPs were emailed with that handout pertinent to their particular area of Scotland. So a clarity of approach is vital. Also for me, it's about role modelling co-productive behaviour. Working co-productively, there's a whole spectrum of that, as I'm sure you'll all know, from down at the bottom end where all it is tokenistic, well, we'll listen to you, or well, we won't really listen to you, to the other end where there is absolutely clear co-productive working and people with lived experience are viewed as equal partners. Now there's a whole load of stuff in the middle of there. For me, it's really important to role model co-productive behaviour and the process of that throughout any interactions that we have with other partners, with Scottish Government. And it's to keep doing that like a broken record, to keep talking about it, to keep asking for what we want. And it is about working together and identifying and continuing with meaningful ways of working. Thank you for your time today and happy to answer any questions.
Okay, well, thank you very much. Here's a large question. Hello, Dr. Kevin and team. Thank you for your presentation. I'm a medical doctor. My observation is around the relationship between stigma, vaccination, living long with COVID-19, and hospitalization. You still see vaccination hesitancy in our communities, and is there a way we can improve engagement in care for many living with COVID-19 and addressing the stigma? I have worked on 2 continents, Africa and in America. It is what informs my observations and curiosities. Right now, I can tell you that anti-vaxxism in America is on steroids and spilling over into other diseases. It is extremely hard to break through on social media. I really feel that some of it's being driven by AI and bots. It's highly organized. Some of it's being driven by, I think, adversaries of the United States to create disinformation and sow social unrest. What I've seen, it's extremely difficult at this point, because if you go one-on-one with someone on social media, it's very inefficient. It takes up your time, and you actually could just be talking to a AI bot. Social media is extremely difficult to do right now because not everybody on social media is a person, and in some sites, it's even less than 50% are actually people. There was an article in JAMA Internal Medicine that described how AI could produce over 100 unique blog postings of misinformation in 65 seconds. And these blogs can be even more persuasive than those written by humans. Sally, do you have any experience to add, or Jane, or?
Are you talking about anti-vax in particular, or?
Yeah.
Oh, yes, so obviously it's right here. I think these days it's less that, it's more the fact that people have got no idea that COVID is still a thing. So why are they going to bother to go and get vaccinated? It's over, it's done with. So on the one hand, you've got governments pushing messages to go and get vaccinated. Meanwhile, they're also pushing messages that COVID doesn't exist. So consequently, people are just going, well, it's just a cold, whatever. So in the early days, though, there were issues around take-up amongst Black and minority ethnic groups in particular, and people who were socioeconomically disadvantaged. So there were certain issues there. I don't know to what extent those were ever properly researched, but these are there was a suggestion that these are groups who possibly have a bit of a track record of poor experiences with interaction with healthcare, and therefore we're going to be particularly skeptical about a vaccination that had been developed so rapidly. So in some ways, yes, there is certainly anti-vax, as in the kind you're discussing, where it's quite targeted, calculated, orchestrated. But I think generally it's just apathy at this point.
Think about it this way. The average person doesn't understand science. They don't follow it. They don't even know the difference between a virus and a bacteria. And so they look to their leaders for guidance. I mean, you have to have government agencies that are communicating reliable, trusted information. If you don't have that, the general person in the public basically figures out they're being gaslit, but they don't know what the true story is and can't figure it out. The general public now that's just becoming very confused on who to believe. And that's very hard to overcome. Jane, any thoughts?
I think it's, as you say, it's very hard to overcome. I think the anti-vaxxing movement is alive and strong. Certainly here it is. You see it online. I think it's largely covert, though. Other than that, I posted in the chat there, it was a few weeks ago, I was admitted to hospital. I was in the emergency department twice in a couple of months. And, I was, well, on one occasion, I was the only person in a mask. And the second occasion, in 24 hours, there was just me and one other person in a mask. And it's a large hospital. So, yeah, I was very disappointed with that. And, for me, certainly the emergency department was very crowded, really lots of sick people, quite scary, a lot of coughing, a lot of all of that sort of spread of infection, and nobody had a mask on apart from myself. Thankfully, I did. Yes, I think it's very hard to address that misinformation. Very hard.
We certainly have our work cut out for us, but similar to the tobacco years, with hard work, I believe public health will prevail. Thank you all for attending this short webinar. At this time, I would like to thank the speakers. Excellent presentations, and we hope to see you all next month. Thank you.